Hi, this is Ashri. I'm going to talk about today one of my patients who I saw on a Saturday morning, literally this morning. So this patient is 35-year-old, a female patient who originally came to the clinic for a steroid injection in her knee, and the case was bilateral knee pain ongoing from past few years, which is not resolving with physiotherapy, neither with exercises. The knee keeps on swelling, and the patient had taken naproxen, which helps transiently, but it keeps coming back. Today, there was no swelling in the knee, but the knee was quite painful with any movement. In the history, patient also mentioned that she has got ongoing lumbar spine pain with sciatica of the left side. So she had a known case of lumbar spine with sciatica from past 3 to 4 years, and at the moment the sciatic pain decreased, but her back pain keeps on going to a point where she actually had to take some of days off from her work. On more questioning, the patient reported in the last 6 to 7 months, the back pain has considerably gone worse to a point where she wakes up every night with pain. And to relieve the pain, she actually does the exercises that was given to her by the physiotherapist. And she's quite happy with the exercises, and she feels the exercises are helping, but it's just every night from past 7 to 8 weeks she's waking up. And once she walks around and does the stretches, she feels better and she goes back to sleep. Among all of that thing, so far she has told me, I think this particular thing on more questioning, I'm glad I asked about night pain, as we all routinely do. It just kind of struck me. And since then, my whole of the assessment was focused more on more autoimmune or ankylosing spondylitis, as you might have thought the same what I'm thinking at the moment. Now, when I dug a bit more deep into the case, patient mentioned she did not know if she had any family history of any form of autoimmune condition. But what she did tell me was, although this back pain is ongoing for 4 to 5 years' time, she has slowly and gradually developed this knee pain, which started with the right knee and again to the left knee. And at this point, she denies to have any morning stiffness or morning pain, but obviously the night pain with the back. With the knee, I'll come to examination, or on the examination, there was no biomechanical changes, no history of trauma. There was full range of motion. There was nothing that could really explain to her knee symptom. However, she works in the desk, but she also works as a decorator, and as a part of that, she kneels a lot. So, which is why initially it was thought to be more mechanical. Now, she also had an X-ray 2 years ago in her home country in Europe, and she did not have the report because the report was not in English. Fortunately, she had the imaging of her sacroiliac joint pain, which I've posted below. I checked the X-ray report, and the X-ray was already had quite radiological changes in the sacroiliac joint. So in her sacroiliac joint, there was a lot of sacroiliac changes. Obviously, it was probably not looked at before, or neither she had an X-ray through NHS. So my focus was completely off from her knee, although she was here for the joint injection, but I was focused more on her overall symptoms. At that point, then I started correlating her back pain to her knee pain and other things. Upon more questioning, she also mentioned recently she's having a bit of bowel issues. She always had, she couldn't tolerate spicy food, but recently her bowel habits has changed. Now, at this stage, I am thinking more towards the ankylosing spondylitis purely based on the clinical history. In terms of the bloods, I checked her record. I couldn't find any blood test that's been done. Last year, some of the blood tests were done to check her inflammatory markers, but everything was negative. So my action plan was I referred her for a whole spine MRI, because as we all know, ankylosing spondylitis can affect the whole of the spine, and ideally I think that's the best course of action to see any changes. Although X-ray is a quick measure, because I had the X-ray, I could see the X-ray, although not the report but the actual film, and she already had developed radiological changes in her sacroiliac joint. And any radiological changes with any inflammatory or autoimmune condition just indicates that the disease process would have been there for a long time. We do not find any radiological changes unless the disease has progressed to some extent. And the same holds good for rheumatoid arthritis, for any autoimmune conditions. And this is why we rely heavily on the blood test. Now, with this particular patient, I then arrange a series of blood tests, which involves a ESR, CRP, and anti-CCP, which is which is a crude marker for rheumatoid or autoimmune profile. And I also arrange anti-Rho and rheumatoid factor, and obviously HLA-B27. Now, the important thing that I wanted to mention here is that in ankylosing spondylitis, unlike the other rheumatoid-like or autoimmune condition, the blood tests tend to be usually normal or positive. This patient had a series of blood tests last year. She had been checked for rheumatoid factor, ESR and CRP, although not anti-CCP and Rho, because that's only done in the secondary care, and she did not have any X-ray or MRIs. So I'm still waiting for the blood report, but the MRI has come back, and it shows very obvious changes in the sacroiliac joint. There's erosion, there is edema, so kind of confirmatory for ankylosing spondylitis. We are yet to get the blood report about all her inflammatory markers was quite high, but the HLA-B27 is yet to come. Now, in this case, when there is a strong clinical suspicion of ankylosing spondylitis purely on the basis of the clinical history and examination, in the examination of the lumbar spine, the Schauber's test was mildly positive. I wouldn't say there was actual stiff spine, but what was quite evident was she had marked tenderness in her bilateral sacroiliac joint. All the other tests like Faber's test, sacroiliac joint stress test, those were positive undoubtedly, but I did not even go to that because she already had a lot of tenderness isolated to the sacroiliac joint. So along with arranging these blood tests, because this is part of the secondary care action, I also referred her to the rheumatologist. So the whole point of making this video is to make everyone aware the diagnostic delay in ankylosing spondylitis, be in primary care and secondary care. And purely because there's a lot of overlapping symptoms. Patient with ankylosing spondylitis, usually the symptom starts as more mechanical, and the back pain, the knee pain, the Achilles tendonitis, unlike what we read in the books, but when you actually see the patient, it may not be that obvious. And a majority of the time, these symptoms actually present as mechanical back pain. So it's quite important to dig a bit more deep into, like in this case, for example, there was no family history, and she actually had some sciatic pain in the back, and she had knee pain, which could be either mechanical. But I think it's important to kind of get everything together and start to correlate, and that's where we can suspect a bit more. In this case, it was quite easy because of the night symptom that she said. You just cannot go wrong. If someone is waking up every night and they have to walk to feel better or do stretches, so any back pain, and like the mechanical back pain, which gets better with exercises, which gets better with mobility, think about some sort of autoimmune or inflammatory. And plus, obviously in this case, she also had a long-standing, it was kind of very obvious that she was getting swelling in the knee. And the other important point that she mentioned was every time she takes naproxen, the pain is better. So naproxen, anti-inflammatory, helping the pain is actually one of the sort of confirmatory sign, you could say as well. Now, in terms of the treatment, so rheumatoid arthritis is a seronegative rheumatoid arthritis, and the criteria, NICE has set a very clear and precise criteria to be able to refer to rheumatologist. Bilateral sacroiliitis is a crude and very classic feature. And if we find all these things, you can straight away refer to a rheumatologist. And the patient need to start on biologics. There are different forms of biologics, and it's quite complicated than the other anti-rheumatoid drug, because biologics, they have to have a series of blood tests to be able to start with biologics. particularly with Asian patient, because I had a similar patient before, and patient who have grown up in India, Pakistan, or some of the South Asian country. It's important that they do the latent TB test as well. So if it's positive for latent TB, then they need to start on antitubercular drug before starting the biologics. And similarly, there's a lot of prerequisites, before you could start biologics. And unlike the other drug with biologics, there's a process of approval in NHS. So the whole point of mentioning about biologics is that it's not quite straightforward. There's also a wait time for the biologic to be issued. So where possible, if you see such cases, please, please, please do consider ankylosing spondylitis as one of your differential diagnoses and think about it. Thank you.